Hello everyone, and thank you for joining us today. My name is Cheryl Fatibene. I'm the Chief Nurse Practitioner Officer at the NNCC, and on behalf of the National Nurse-Led Care Consortium and the AANP, I would like to welcome you to today's Lunch and Learn webinar, EHR Implementation for Small and Rural Primary Care Practices, Part 2. Our presenter today is Rebecca Freeman, the Chief Nursing and Informatics Officer at the University of Vermont Health System. Today's webinar is being recorded and will be available in the upcoming week on our Nurse Practitioner Support and Alignment page, and a link to that recording will be sent to all registrants. All participants will be muted throughout the presentation. I encourage you to submit questions during the presentation. Please use the Questions tab on your GoToWebinar control panel, as seen here, to ask your question. It will be relayed to the presenter and answered at the end of the webinar. A survey will pop up at the end of the webinar and will be sent in an email later today. Please take a few moments to complete the survey evaluating this activity, as your feedback is critical to the ongoing development and presentation of our webinars. The slides for today's webinar are available as a handout, which you can access via the Handouts pane, as seen here in the control panel. You can click the name of the handout and it will be downloaded via your default web browser. I'll turn it over at this point to my colleague Joseph at the AANP to tell you how you can receive CE credit today.
Hello everyone, this is Joseph with the American Association of Nurse Practitioners. Today's webinar presentation is accredited for continuing education credit by AANP. There are a couple of requirements in order to qualify for CE credit. The most important of which is that you have to attend at least 55 minutes of this presentation. And by attending, we mean you need to attend not only the audio presentation, but also the slide deck presentation. You need to view the slide deck in real time. So if you're only calling in today and you wish to receive CE credit, go ahead and disconnect from the phone or stay connected to the phone and also click the registration, the webinar link that gives you access to the slide deck so you can view the presentation in real time. That will be imperative in order for me to determine who qualifies for the webinar and how long they attend the webinar. For those who do qualify, at the end of the presentation, you will receive an email from me. It'll be a proactive email reaching out to you to let you know that you qualified for continuing education credit. In that email, I will give you specific instructions on how to access your CE credit on the AANP website. If you are an AANP member already, or if you already have an AANP account, a free account, be sure that you, hopefully you used the same email to register for this webinar as you used to access your AANP account. If you did not use similar emails, go ahead and email me. My email is listed there, jreyes@aanp.org. Send me an email to let me know that you registered with two separate emails. So the email you used to register for the webinar is different than the email you used to access the ANPC Center. In that case, you will have a problem and you won't be able to access the CE Center. So go ahead and email me to let me know so that we can take care of that issue beforehand. In that email, I'm going to give you a passcode, and you're also going to be required to complete an evaluation that is separate from this webinar evaluation. So in essence, you will complete two evaluations, one on the CE Center and one for this webinar directly after. And that's it.
Thank you very much. So I wanted to take a moment today to talk about the national investment taking place for quality improvement in the United States with the help of our federal government and the organizations who are presenting this content as part of the Transforming Clinical Practice Initiative, or TCPI, which is sponsoring today's presentation. The TCPI, or Transforming Clinical Practice Initiative, is CMS's largest ever investment in practice transformation, with an investment of over $700 million over 4 years and enrollment of 150,000 plus providers across the country. The NNCC, or National Nurse-Led Care Consortium, is a membership organization with over 250 nurse-led practices on our membership roster. Our mission is to advance nurse-led care through policy, consultation, and programs to reduce health disparities and meet people's primary care and wellness needs. Our partner in this initiative, the American Association of Nurse Practitioners, is the largest full-service national professional organization for NPs of all specialties. It is leading the way in advocacy, continuing education, and professional development for over 77,000 members. CMS funded the NNCC and the AANP to support enrollment of NPs into practice transformation networks, or PTNs, across the country, and to develop NP-specific educational material that facilitates practice transformation in advance of the upcoming payment reform changes with CMS. The NNCC and the AANP are the only nursing-focused grantee of the TCPI project. The NNCC and the AANP agree that this initiative is important to ensure nurse practitioners receive the support they need to remain competitive in a changing healthcare landscape. NPs are the future of primary care in the United States and already provide high quality and cost-effective care. This initiative is an opportunity for NPs to prove it by helping CMS and the broader healthcare community build the evidence based on practice transformation while preparing for value-based reimbursement. I'd like to talk to you also about the national investment taking place for quality improvement in the U.S. with the help of our federal government. Let's see. So as we get ready for value-based reimbursement, CMS is funding the TCPI clinicians across the country for value-based care. In order to remain relevant within this value-based reimbursement system, you need 4 elements, and those elements are reporting on the quality of the care being delivered, report on the quantity of care, the fee-for-service element, quality improvement or CQI activities in your practice, and the use of health IT that support the work that you do, also known as meaningful use. The providers will receive payment adjustments beginning with January 2017 results, and those first payment adjustments will be paid out in 2019. So TCPI provides clinicians with all of these skills and resources in order to work in these critical areas. If you have these 4 elements in your practice today, you will be ready for payment reform. At this point, I'd like to turn our presentation over to Rebecca Freeman to talk to us about EHR implementation. Rebecca?
Thank you, guys, and hello to everyone who's joined. Thank you for joining us today for part 2 of a 2-part series on EHR implementation for small and rural primary care practices. For any of you that didn't see part 1, these guys have it available online for you to go back and watch. We did record it. You'll notice that we had a different template and I had a different email address on that one. So if you do go back and watch part 1 and you have any follow-up questions, I am super happy to field those. Just be sure you send them to the email address at the end of this presentation, which is current. Part 1 really focused on how to select an electronic health record, the things that you need to think about before you switch from one to the other. And part 2 today is going to focus a little more on what happens after you choose your record. It is geared towards small and rural primary care practices, but there are a lot of these things that are very basic, that are not specifically just within the domain of small and rural primary care, but I do try to provide in this presentation a lot of self-help options. So places you can go online. We'll look at a few resources at the end, and you are more than welcome to ask questions at the end of this presentation or to shoot me an email after. I will talk to anybody about just about anything. So with that in mind, we will go to the next slide and look at our overview. So today we're going to talk about adoption and implementation, optimization. So once you get the system in, how do you make sure you tweak it so that it's working as efficiently as it can? Data migration, which is a big deal only if you're going from one electronic system to the other. So if you had an EHR in place and you're going to a new one, what are you going to do about all those pieces of data that are in your old system? And then we're going to go through those resources to help that I was talking about. I am going to go very quickly over all of these things today. So very shallow, very broad, and again, I am happy to follow up with questions and answers afterwards. So let's go look at adoption and implementation first, and we'll go to the next slide. So the funny thing is, this is an electronic health record. It's a technical project, but the thing about EHRs these days is really that so much of it is about having the right team in place and change management. I am working at the University of Vermont now, and we actually did a presentation last week, and we told all of the clinical leaders that 80% of the success of getting this thing in place is going to depend on them taking clinical ownership of the system. 20% is going to be technical, because honestly, you can implement anything, anywhere, relatively on budget and on time. So the IT piece is not nearly as difficult as trying to help folks who don't know how to use the computer very well, who don't have time for training, who don't necessarily think that the electronic health record helps. Provider burden, clinician burden is a big deal right now. So getting the right attitude as you put these things in place, it's critical. It's probably the most critical thing. Now, if you're a single provider in an office and it's just you get to work on your own attitude, which is kind of fun. We'll also talk about training. We'll talk about cleaning up your documentation and your workflows, addressing policies that might need to be addressed, and then data and analytics, which even on a small scale are usually the reason you're putting the system in place in the first place, so that you can get data out, either for regulatory reporting or to better manage your patient population. So that's the general setup for success of an implementation. And let's go to the next slide. So John Cotter is really a seminal author in the field of change management. He's written 1 million books, and they're all really good. But this is a little three-phased approach to how you manage change. So you have a current state. First, you need to look at the culture. Is the culture ready for change, or does everyone hate the current EHR and they think they're going to hate the next one and they don't want the change? If that's kind of where everyone is, you need to do some work there. You need to understand exactly what's in place. And then you need to move to phase 2, where you start to engage people. You start to enable people to get involved in the process. Try to help turn the complaints and the dissatisfaction into things that you can actually identify that are wrong, and work to fix them with the next implementation. And as difficult as it may be to think about, the folks who are complaining the most loudly are usually the folks you need to spend the most time on. Because you can flip them, a lot of them, if you can get them engaged and get buy-in. And then phase 3, I always tell people getting to go live is such a tiny part of the life cycle of the EHR. So just because you flip the switch and it's in place and that's great, there is a whole bunch of stuff that happens after that. So you don't want to drop off the map. You want to make sure that you're implementing and sustaining all of the changes you put in place. And I'm talking about mostly behavioral and attitude type changes, but also any workflows or processes or policies that you changed. You want to go away 90 days after you get the system in. Future state, we just threw a few things in there. We could be looking at the successful move from paper to an electronic health record, or maybe you achieve meaningful use or something under the quality payment program or an alternative payment model, upgrade, replacing the system you had in place, and then some of these, as I said, these other APMs, maybe you were able to achieve what you needed to participate fully. So just a little bit on change management, and we can go to the next slide. So training to me is one of the key things, and we hardly ever focus on it as much as we need to, because it takes time out of clinic and it's expensive. Trainers are expensive, and taking time out of clinic is expensive. So this is something that frequently gets short shrift, but it's probably one of the most critical things you can do. So we talk a lot right now about electronic health record usability, and I always say if you don't know how to use it, it's not very usable. So the best system in the universe, unless it's 100% intuitive, and honestly healthcare is just too complex to create a system that is 100% intuitive, you need training, and you need ongoing iterative training. So you need to think about these things if you are thinking about putting an electronic health record into your practice or tweaking your health record that you already have in place. For a new go live, who's going to do the initial training? Your vendor will almost always have trainers who can do that for you. That is probably going to be part of the initial contract. You may want them to stay for a little bit of extra time. They may offer you the opportunity to hold on to trainers for a week or two after go live to be at the elbow support. If you can figure out how to make that happen financially, I highly recommend it. You could also do a train the trainer. So maybe you have those trainers on site for a week or two, you get your training done. If you can identify an internal candidate or two who can spend extra time with the trainers and then take over that role when your vendors leave, that's really good. The third option is a consulting trainer, and there are lots of them out there for every system known to man, but they are pricey. They're usually going to be pricier than, actually, I don't know that pricier is a word. They're going to be more expensive than your vendor-based trainers for the most part, and obviously if you train someone internally, that's an easy way to kind of assign a role without having to pay a whole lot of extra money. So think about who's going to do it. And then when the system goes into place and the trainers leave, either the consulting or the vendor trainers, think about what happens with refresher training. Who are you going to have in the clinic when someone says, I don't know how to do this? Who are they going to raise their hand and ask? Is there an internal super user? Is there a help desk that comes along with your vendor? You want to think about those types of things as you're vetting your systems, and then you get them in place. The other thing is, where are you going to train? Do you have space? Do you have computers available? You want to have hands-on training whenever possible. There are places that lease computers. There are vendors sometimes who can bring in laptops so they can set this up for you. I have done training, and I joke, every closet known to man, but I have. Anywhere that we could shove a table and a couple of laptops is suddenly a classroom. So be creative and think about how you're going to do that. You have modalities and duration. So I had a friend who started at a hospital, about 3 weeks ago, and she texted me, and she was doing her orientation training, and they had sat her down in front of a computer with 83 videos to watch. So no in-class instruction, all online modules. And she and I were talking about how, she was going to retain nothing from 83 online modules. And at the same time, you don't want to sit someone in class for 4 days. They won't retain a lot of that either. So think about how to find a balance between learning enough to be able to log in and use the system on day one, but how to have follow-up help a weekend, 2 weeks, 3 weeks, 6 months in. Once you get a little more comfortable, your brain opens up to hear about some of those features that can actually make you more efficient. But if you try to shove all that in one day, it's just a mess. So think about this from a training standpoint. And then in terms of upgrades and patches, you just need to think about what happens with that. So if you take an upgrade a year or two in, is it a minimal upgrade? Is it going to change anything significantly? If it does, you're probably going to need some follow-up training. So just keep that in mind, that all of these things need to be trained. And if you don't do the training, if you skip this part, your ability to use the system and do what you need to with it is going to be minimalized to a large extent. So that's my soapbox on training. We can go to the next slide. Documentation, workflows, and policies. Each of these could also be a soapbox, but I promise not to hang out as long on these. So documentation, does it match your workflows? And are your workflows efficient? And most of the time, you guys know when you have an efficient workflow and when you don't. It's a lot of work to change it, to study it and change it, but just think about it. If you are on paper and you're moving to an electronic health record, please pay attention to that bolded sentence. Don't just take all of your paper forms and hand them to the vendor to be rebuilt in the system. The computer can do so many things for you, but it's really not the best repository for the replication of 100 paper forms. And we did that all over the place when we started implementing EHRs. No one would sign off on it if their document wasn't exactly replicated in the system. And a lot of the problems that we have now for interoperability and documentation burden are related to the fact that we just replicated bad workflows and poor documentation forms into a system, and now it's kind of an ugly mess. So as much as you can with documentation, make sure it's streamlined. Make sure that If you ask a question in one place, you don't ask it again in 4 other places, or you'll find that replicated in your electronic system. Again, from a workflow standpoint, make sure they're optimized and efficient, and there is an intersection sometimes between new technology and cool new things you can do with workflow, because you don't have to do these 5 steps that were paper-based anymore, or maybe they were based in your old system. So just be sure you think about that and do the legwork ahead of time to make your system as efficient and effective as it can be. From a policy standpoint, I always say there's big P policy and there's little p policy. So to me, big P policy is state and federal policy. That is work that needs to be done at a high level. You guys are fortunate in that you have a handful of hardworking organizations who are doing that kind of lobbying and work for you, but please get involved if you can. You want to maximize your ability to work through policy at that level. At the facility level, you'd be surprised how much a little tweak to a facility or practice policy can impact your workflow and efficiency. So keep in mind, especially if you change documentation or if you change workflows, if those things are being underscored by an existing policy, you have to revisit that policy as well. Does your IT build mirror your policy? It should, because you should know what those are. If you have an individual practice that you own, or you're a partner in a small number of partners, usually you're inherently familiar with your policies and you'll make sure the IT is built the way it should be. If you are an affiliated practice with a large system, you might kind of be on your own, but there also might be policies in place that you need to make sure you account for with the IT build. You don't want to run into problems down the line. So just keep in mind that you might have to change your policies based on your IT functionality, and sometimes those changes are for the better. I think actually most of the time they are. Let's go to the next slide. So workflows. Perspective is everything. This is a workflow from a primary care practice when we did an implementation, and the one on the left is what we thought we had. Now, we thought we had that workflow because we talked to a couple of people about what the patient flow process through the clinic looked like, and that's where we kind of thought it was. And if you see there on the left, you've got the patient registering, and the registrar puts some stuff in, and then they go to the CMA, and then off it goes. So that was it. And then we came to a grinding halt on day 1, and we really couldn't figure out why. And after we did some formal workflow analysis, what we ended up with on the bottom right is really what the workflow looked like. We didn't map that super well because we didn't do a really solid interview of every single person as part of the process. And if we had, we would have realized how many points of entry and exit there were for information, for results. There were devices we had totally forgotten about. So just crazy stuff. So keep in mind, if you think your workflow is super simple, make sure you talk to every person who touches it and make sure you really understand, because sometimes you don't know what that person does when you hand off something to them. You just know that magically things happen and you get a result at the end. So make sure you have that well in hand. If you actually have the workflow on the bottom right and you design the EHR for the workflow on the top left, you'll be very sad on day 1. So that's it for workflows, and I'll show you at the end. There are a couple of places you can go to get all kinds of help with kind of diagnosing and tweaking your workflows. So let's go to the next. Cool, taking a breath. Okay, so the analytics plan, there are a couple of kinds of analytics that you need to think about. So one, I call these kind of the operational reports. So these might be financial reports. If you have an office manager and you're not serving as the office manager, there are going to be all kinds of reports related to income, related to patient volume, maybe to access, all sorts of things that you need in terms of being able to manage your business. There are some that currently exist, and you need to replicate those in your new digital record. There may also be future reports that could help your business significantly, but you just can't get to them right now. So think about what those would be and make sure that your vendor is able to help with that. You're also going to have regulatory reporting. So what do you need? What do you need in terms of quality metrics? What do you need in terms of making sure you have all your ducks in a row for reimbursement to a variety of vendors? Just think about those things and know ahead of time going into prep for that implementation that you have that together, and then as soon as you go live, make sure that you validate your reports. It's a little bit of a pain to do that, but you don't want to trust that they're exactly right, and sometimes you can do that validation before go live, but it really helps once you have actual data in the system and you're up and running to run all of those reports and have someone take the time to manually go back and just compare apples to apples and make sure you've got what you need. So from a report and data types section, there are just different types of reports. So historical reports, those are easy. Those are just, hey, what did I do last month? What did I do last week? What was my volume like yesterday? Population management, especially if you're looking at APMs, but even if you're not, just knowing what the overall health of your hypertension population or your, geriatric population within a given age range. There are lots and lots of tools that are now built into these electronic health records, and they may help you take care of your population from a higher level of analytics than what you currently are able to do. Dashboards are more real time. So in an inpatient unit, this is a really easy thing to give an example of. If you have a provider with a list of patients to see, or a list of follow-up things that need to be done, or for a bedside nurse, the things that are due on a 12-hour shift, you can have red and green, and there are just lists and tasks out the wazoo. But you can do dashboards in the ambulatory and outpatient setting as well. And it really is related to, here's a patient, here's a really nice graphical overview of that patient, and then you can use colors and bolded fonts to really make it easy to see what needs to happen, especially from a health maintenance standpoint. And those are not historical or population management reports. That is real-time right now, actionable stuff that you can do. It helps with your care. And then the operational reports we talked about, those are really your business-related reports that you need. And I would fit regulatory under there. So think about who does that in your practice. And if that's you, then you're ahead of the game. And if it's not, make sure that you're working with the person who owns these to make sure that you have what you need and that they're working once your system is in place. When it comes to analytics, prioritize and work with your vendor. Think about bringing in a consultant. There are consultants who live and breathe nothing but analytics and reporting, and they are so good at it. And paying them to come in and work with you is kind of a steep hill to climb sometimes, but they are so much more efficient than most folks who are just trying to kind of bulldoze their way through analytics and data when they don't really understand it. Even a solid day with a really good analytics consultant can make a huge difference. So really, you just want to think about, how am I going to make the system work for me? You're probably going to have way more requests and ideas for data than you're actually going to put in place with your first implementation. So line those things up, prioritize them, and work hand in hand with your vendor to make sure you get what you need. All right, next slide. So optimization. This is the stage for, I've got my system in place, and now what am I going to do? So let's go to the next slide. Yay for implementation. And there's always, trust me, if you've ever been through a go live, and I bet most of you have, there's this period of kind of 24 to 48 hours where everyone is pretty happy, mostly because the thing didn't implode. So their expectations were not met, it's better than they thought, and they're kind of up and running. That tends to fall off a cliff in a hurry because all of a sudden things start to pop up. You don't like the way this looks. This thing appears to be broken. You wish you had done it this way. So what are you going to do about that? And if you don't jump on that fairly quickly, satisfaction tends to kind of bottom out. So think about, who are you going to call for help? So the minute you have go live happen, is there a help desk for the vendor? Are you going to get cell phone numbers for all of the vendor folks who are online, and how are you going to triage out problems to each one of those? If you're part of a system, do you have a help desk? And what are you going to do if they're not particularly helpful? If you already have a help desk through the system and you know right now that they're not particularly helpful, that's probably not going to change for your go live. So come up with a mitigation plan for what you're going to do. Have that plan for ongoing support and training. Have a plan for prioritizing your issues. And what I mean by that is if you have 2 providers in your practice and a nurse and a couple of CMAs and some other ancillary staff, and everyone has 5 problems they want to call in, how are you going to triage those things for the poor folks who are answering the phone? Because the person answering the phone really doesn't know how to prioritize one of those problems over the other. And if you're not careful, what you end up with is, a bucket of 50 problems in the first 4 or 5 hours, and they just kind of take them first come, first serve. So I always tell folks when go live happens, if you can work out an internal process for triage, and this is my ER nurse talking here, do that before you call anybody so that you can say, this is our top priority, I need you to fix it. Or this is not a high priority, it's fine if it waits until next week. If you can help with that kind of information, you can get the things that are important fixed more quickly. And then from a workflow design and redesign standpoint, just think about as you look at your staff in your clinic, how are you going to perform an ongoing assessment of your workflows? What was great on day 1, 6 months later, things might change. The look of your organization or your clinic might change. And as those things happen, how are you going to account for those in the electronic health record? Okay, next one. Informatics assistance, i.e. help. So hospitals have an army of informatics help. Now, if you go talk to folks in the hospital, they'll probably tell you they still wish they had more help. But there is usually a variety of IS and IT and informatics staff there. When you get out of the hospital, not so much. Even the ambulatory practices, especially smaller rural practices, folks who are working in community settings, schools, not so much. There's just not so much help out there. So what are you going to do? Well, for one, you can be self-reliant, so you can educate yourself on the system. You can also, I always say students are the best free labor in the world. So if you can get a technical school, a local 4-year school, maybe even a graduate school, MHA students are great. They need experiences. They need hours, usually as they're gearing up towards graduation. And even if they don't, if you can go talk to the folks at the colleges who are managing time for those students, just say, I could really use some volunteers. You'd be surprised by how much help you might get. And I don't want to be ageist here, but there are a lot of youngins who are really good at technology and they pick it up incredibly quickly. And a lot of you on the line might be the youngins. But if you find yourself needing help, don't give up on getting some volunteers from local schools or communities. Folks are really happy to help, especially if you are doing the work that helps them so much. Another option is the Federal Technical Assistance Program. So MACRA and the Quality Payment Program designated $100 million over 5 years for technical assistance specifically focused on small practices and rural health and professional shortage areas. So I included a link here that has a fact sheet about that work. So if you can't find a volunteer, and you don't have an army of informatics help through a system that you're affiliated with, reach out and see what you can get through this technical assistance program. They also offered technical assistance for the Meaningful Use program. That has actually wound down, so I was really happy when they gave that $100 million to continue technical assistance under MACRA. So there are options for you, even if you don't have a big IT system to help staff you on the back end. All right, let's go to the next page. So now we're going to talk about a big one, data migration. Let's go to the next page. And for those of you who are thinking, oh my gosh, she's given me 10,000 words, I only really have 2 more big slides, and then we'll talk about some resources to help. So think about data migration. You have to understand not only if you have an EHR in place right now, you need to understand the contract that you are currently under. Do you own all of your data? And if you switch to a new system, will they migrate that data for nothing? Frequently, you don't own all of your data. You can certainly get it migrated, but the problem is you're going to have to pay for it. And a lot of folks don't understand that when they sign the contract. So make sure you understand the contract you're operating under now. And when you sign the contract for your new health IT implementation, Make sure that you understand the costs that are going to come on that end to get your data out of your old system and into the new. Clearly understand your financial resources. So I can just tell you, this is really expensive to build interfaces for all these different buckets of data. So think about what absolutely has to be migrated and what can you just historically store and go back and retrieve. And for anyone who's been through an electronic health record change out, you know how this looks. So, you know, the last 6 months of lab results might be moved over. If you want a lab result from 3 years ago, you probably have to go log into a different system and retrieve it that way. Doesn't mean you can't get to the data. You absolutely can, but it's just not right there in front of you, integrated as part of your new system. So just think about this. I find frequently when we start talking dollars, things that absolutely have to be migrated suddenly aren't so critical anymore. You can just go back and look in the old system. This is also where Google can really help. If you go on and Google data migration, you can find a million little articles about considerations and things to think about. Think about workflow impact. Think about if you fail to migrate certain types of data and you have to go back and log into a different system every time you want to see that, what's that going to do to your workflow? Because that 30 seconds multiplied times 10 every day, 5 days a week, can really amount to real time. So just think about what you're going to do and what the resulting workflow will look like. And then again, if you have the money and can swing it, engaging a data analyst consultant for assistance is really helpful, and you can get those externally, but your vendor can also probably help with this. They can help you scope out the pricing on all of those interfaces that you might want to build, but this is something that you're definitely going to be faced with, and you just don't want to be surprised when you get to the end of the line and finalizing your contract to discover that you're going to be missing out on a whole bunch of data. And if we go to the next page. So the data format, this is another thing. So if you're in a system, an old system, you might be able to migrate the data to the new system. But are they the same language? Are they located in the same format? If they're not, what you're going to find is you might have, let's say, health maintenance alerts that would fire based on certain pieces of data. But if you don't migrate the old data, or you migrate it and it doesn't match up, it's not interoperable, then all of your clinical decision support alerts are not going to work. They'll work on the new data that you input. So, you know, after you've seen everybody once or twice over the course of 12 months, now their annual pop-ups will start working again. But you just want to think about those things as you're working with your vendor on design and they talk about all of these amazing alerts that they can use. Just be sure to think about, oh, well, what if we don't move these pieces of data? Make sure you understand how that's going to impact the ability of these alerts to work. And there is a resource, the Migrate Your Data section of the Health IT Playbook. And then under that, as I said, Google. I actually did some Googling and I put in quotes what I would use as my Google search string. And you'll find a lot of articles that are written in very plain language, very easy to read format, and they will help you as you're trying to move forward with this data migration piece. So we will now move on to talk about resources. I know I've filled your head with a whole bunch of stuff, so let's talk about where you can go to help. First one, let's go to the next slide. So the AMA actually put together a really amazing set of educational modules, and I laugh because I'm not always talking about the AMA and how awesome they are in my presentations, but I will absolutely give them 100 times of credit for this. The link is at the bottom, and when we finish these in the slides, we can actually show you really quickly what these look like online. But this is a series of modules. They have probably 10 just on workflow redesign, and they have them in multiple modalities. So if you want to watch a video, you can. If you'd rather read the PDF, you can. So I really like the way they put these together, and we work with them to incorporate them into our Health IT Playbook when I worked at ONC. So it's a great resource for learning. If we go to the next slide. The contract guide, when I talked about understanding what's in your current contract and understanding how to set up your next contract for an EHR, lots and lots of people wrote into us when I was at ONC, as you can see it down there, the Office of the National Coordinator for Health IT. We had a lot of questions come in where people just did not understand what they had signed, and now they felt like they were kind of over a barrel. So our policy team, full of lawyers, amazing people, put together this little EHR Contracts Untangled booklet. I highly recommend you look through it. They've made it as easy to understand as they can, and it calls out all of the key points where you might find yourself in trouble negotiating or managing your own contract with the vendor. So I just recommend that for everybody, and I see we've flipped over to it. It's a PDF. You can print it. You can save it to your computer, but it's really great to read through and help you, because honestly, I don't think many of us went to law school or are particularly law savvy. So you'll see there a whole bunch of different ways to do this the right way. We can also flip while we've ownership of all kinds of stuff. Okay, so this is the other one. This was going to be the next slide, but we'll just talk about it here. This is the Health IT Playbook. So with the Health IT Playbook, if you click on the electronic health records section, second box, there you go. It's really easy to navigate, and you'll see on the left-hand side, we have 5 sections. So some of which I just talked about, optimizing workflow, migrating your data. So we have that. We have a section on the opioid epidemic and how to use technology to help with that. There's just a ton of stuff in the playbook, and there's a great search feature. So if you have a question about anything, you can just do a search, and then it'll lead you to all of the modules that we've put in here. A lot of this is not content that we developed, but we vetted it coming from other places. So we kind of tried to find just the best of what was out there. And then really quickly, we can look at the AMA modules. So these are great. If you'll click on that modules button at the top really quickly, I'll just point out, yeah, so they have 16 related to patient care, but you'll see 14 of them related to workflow, 7 of them related to change management, and then technology. Let's just click on technology and finance. That'll be kind of fun. So under each of those sections, it'll go to the subheading, and then you can see what those are. They have models, they have a telemedicine piece here. The macro one is really good. So I just think between those resources, the contract guide, the Health IT Playbook, and the Steps Forward modules that the AMA put together, and I think I've watched every single one of them, you do have some great self-learning modules online. And that is, yay, I finished 3 minutes early. That is the presentation, and now that I have given you a million things to think about, I would be happy to field some questions.
Great. Thank you so much, Rebecca. Certainly a treasure trove of information. Just to point out to people that are on the webinar that the links are all located on the slides themselves, so you can cut and paste those in, or you can type those in for all of those resources that Rebecca has shared with us. There really is a large amount of free information that's out there. I think the trouble many people have is just sorting through it, and I think you've given us a great roadmap. So just as we're talking here for a couple minutes, we did have a couple of questions come through. Some kudos to you for a great job, Rebecca, which I just wanted to echo that as well. And we do have one question. So you had the patient flow diagram,
yes,
earlier in the presentation, and maybe we could go back quickly to that
sure.
particular slide, just because it'll make more sense when you actually see it. So
okay.
We have Renata who asked in this particular slide why we don't see the patient as represented specifically within the flow. So maybe you can just talk to that a little bit about, you know, how you see that
yes.
workflow, because there's obviously a, you know, an idea that the patient would be in each of these steps, but
yeah, so this is, we took some, oh gosh, I hear myself echoing, sorry. We took some liberties with this. So this is actually, And if you guys are familiar with how workflow diagrams look, there are lines and boxes and decision boxes and yes, no's and all kinds of things. And when you're diagramming a workflow, you usually start with Post-it notes and pieces of paper that are 14 feet long mounted in a hallway somewhere. It's an insane thing. But it's really hard to show that on a PowerPoint slide, except to take a picture of it and then you lose all of your details. So this is really just kind of this is a concept, and the concept was you think you know what your workflow is and it only has 14 steps, but when you actually go sit with the registrar for 45 minutes and ask a bunch of questions, you find out that the registrar actually does 42 things to get a patient registered, not just 3, and that the patient comes back to the registrar 4 times during the process, which no one knew about because only the person who sends them there knows about that. So this is definitely not any kind of formal workflow diagram. This is just more a representation of the concept of we thought it was easy and kind of streamlined, and it was a hot mess when we started digging into it. The actual workflow diagrams where the patient, clearly the whole point of the workflow is the patient comes in the door and they do 100 things and then they leave out of the door, and the whole pathway is the patient. But I was trying to kind of clean it up to make a point here. So that's why this is really, for those of you who do process improvement, this is a horrific chop up of that.
Yeah. So Renata, thanks you for that explanation.
Sure.
And I do as well. So we have sort of the parallel of the patients that are walking through this, but really we were more focused on the workflow within an office.
Yep.
A question that I have for you in the work that you've done, both consulting with and working with implementation, maybe
Yes.
you can talk about both the side of best practices and how to do that, or maybe if there's an instance you can think of in your professional life where implementation really had gone wrong and what you or others might have done differently to prevent kind of a catastrophic sort of outcome. So best practices and maybe some lessons learned.
Oh gosh, sure. So best practices, I always start with your vendors. So every vendor has a user community. So if you go with Epic or Cerner or eClinicalWorks, and certainly there are many more. I just picked 3 of the big ones there. There are user groups online. I use the Epic user web all the time. So if I am sitting at any given facility and someone says, I wonder what the best way to do this is, I go right back to my vendor and I say, hey, who does this the best? Because they know, they have implemented their system in a million places, and they know that, it went in this place and it was a complete disaster, and it went in this place and it has been amazing. And I want to talk to those people who did it in the amazing way. So you can use Google for that, but I really do find Google is more generic, generic implementation help, kind of like what I did today. But if you're putting in an Epic and you are a rural primary care practice, you want to go find the other rural primary care practices who also implemented Epic, and how did they do this stuff. And the same goes for Cerner and any other vendor. You'd be surprised how much people want to help each other. So if you say, gosh, I really need a report that does this, well, go see if another client has done it. And most of the time, they'll share that report with you, so you don't have to do the legwork of building it all over again. So best practices for me always start with the vendor and asking for help through the user community. And then I go to Google or a formal literature review if I'm looking for something like that. In terms of disasters, disasters are really funny. So you can go online and Google any vendor, and probably not the word disaster, but pick something, patient safety or revenue loss, and you will find horror stories on the web. But they're never as easy as what people seem to make them appear to be on the internet. So if you have a go live and at the end of week number 2 you have lost 40% of your income, well, something is not right there, and there's no telling what it is, but it could be your charge master was messed up. So you implemented with a back-end revenue cycle document that just wasn't correct, or you skimped on training, so your folks are not clicking the buttons the way they need to in order to drop the bills the way they should. There are really root cause analyses all over the place that have to happen, but I will just say the two key things that I find that can really tank a go live are, number one, change management. So the clinical folks don't own it. IT folks are not usually clinical, and they cannot own these systems for you. They did once upon a time. They would implement a best-in-breed little system, and I always say, you know, Jane, who lives in the closet at the end of the labor and delivery hallway and has been doing centricity for 25 years, Jane probably can configure whatever you need, but that is not the state of the world with these new modern electronic health records. And so you as the clinician have to own the system and work with your IT people to make it do what you need it to do. And if we don't get that balance right, if the clinicians are still hoping that IT is going to own it for them, then it's not going to be a success. And that is probably the key thing that falls apart. Training is a close second, but normally they follow hand in hand. So if the clinical staff own the system, they usually are going to make sure that on some level they have the training and support that they need. But if they're waiting on IT to do it, that's where you really can run into problems. So that's my key thing that I've noticed through multiple years of implementations.
Great, thanks, Rebecca.
Sure.
We had a question come in inquiring about a slide you had about availability of technical assistance, or perhaps it was
Yes.
grant support to help small and rural practices in advance of MIPS. Can you speak a little bit more about that?
Yeah, so what I linked to was, can we go back to that slide actually? I linked to the PDF. So CMS has a PDF, kind of a frequently asked questions type thing. Yeah, right there at the bottom. Actually, if we could click through to that, we might be able to take a peek at it online really quickly. It should be live.
Okay, we're working on that. We're going to open that up for everybody.
But yeah, CMS says, since this was specifically about small and rural primary care practices, CMS has some things that they are really focusing on trying to get to those groups. So this is a little bit about flexibilities and support for small practices, and technical assistance is part of that. You guys may want to go back and look at this. I can tell you at ONC, we have a guy, his name is John Fleming, and he has the world's longest title, which I won't get into here, but he is a Louisiana primary care doc, and he's very unhappy with MACRA. He was also very unhappy with meaningful use, but he made great points, which are probably very similar points for nurse practitioners and in small and rural practices, which is most of these areas don't even meet the denominator to qualify for those incentive programs, and they put a lot of work and a lot of a heavy load on a small and rural primary care practice in order to try to jump through hoops and get a little bit of incentive money. This document is really born out of that, out of kind of the complaints and the feedback from small and rural practices, so that you can see how they're trying to accommodate that in MACRA. And as you go through, you'll see some headings, but there is actually a heading on technical assistance in there. So I highly recommend, when you have time after the presentation, if you can click through to this and just take a look at it. I think it'll give you some good info. There it is, some education and training and TA. So
great, thank you.
That's what that's about.
And noted there on that second bullet point is Transforming Clinical Practice Initiative,
There you have it.
which is our grant that we are working here with the NNCC and the AANP. We did get a question also from the audience asking about web-based platforms, particularly Advanced MD, and what your thoughts are about using a web-based versus other types of platforms, as web-based can be less expensive.
Yep. So I will say, if you go back and watch part 1, I get into that a tiny bit. I can't speak to that particular vendor, but I will say it's very similar to like an Athena Health. If you're a small practice, I never recommend that you go through the process of buying hardware and maintaining your own stuff on site. Most of the vendors who are going to market to you are going to offer that web-based, cloud-based EHR. The pricing structure is usually going to fall in terms of either productivity or patient load. And that's usually a pricing model that works for folks. I love the cloud-based model. If you're in a rural area where you have internet connectivity issues, that's a problem that has to be overcome. But there is no reason for there to be a server sitting in your closet that you have to worry about backups for and all that kind of stuff on site. Put it in the cloud, log into it, and your primary concern there is really, do you have a good solid connection to the internet where you are? So I like that model a lot, especially for small practices.
Great. Another thing that I've been thinking a lot about is even just the educational background that you have with regard to IT, but also being a nurse and nursing informatics in general professionally. It's something that had sort of flown under the radar for me for many years because I figured I was not a techie person, but maybe you can talk a little bit about that intersection of IT and nursing. I believe that it's really an expanding field right now with tremendous potential for both work, and it's very interesting. So maybe you can talk a little bit about your path and, you know, just that field for nursing in general.
Sure. So I actually was not a first career nurse. I worked in IT for about 15 years full-time, and then I went back to nursing school. So I graduated with my BSN in 2008. I did an accelerated program, and then I went right into a PhD program. I won't even tell you why because I'm still not sure why, frankly, but I landed on the other side of a PhD where I focused on interdisciplinary collaboration. Mostly because that was the process I saw as most broken as I worked in the ER for those years. So I had all that IT background, meaningful use came out, and all of a sudden every hospital in the universe wanted to put in an EHR, and there were very few clinical people with a technical background. So suddenly, my friend would say I was the pretty girl at the prom, so it was really easy for me to find work because I could hold my own with the room full of mostly boys from the IT department, and I could also represent the clinical staff and what needed to happen. And that's really where informatics is. It is, you know, you have to have some technical understanding, and you have to have a bedside clinical understanding of what life is like as a nurse. And then you have to be able to meld those two, because when I pull someone off the bedside and start to teach them the technical things, I always say it's going to take 2 to 3 years for you to think like an informaticist, because for the first year or two, you just want to bend the IT to help the bedside staff. But then you start to see the bigger picture of why that's technically not a good idea to customize so much stuff, why standardization is good, how changing a system here can impact a report over there. And once you can start to understand that, and now you learn how to do workflow and process improvement assessments, and you learn about accountability. You know, sometimes people just want to use health IT to make people do the right thing, and that is not the job of health IT. So you have to be able to kind of go triage a problem that's masquerading as an IT problem, make sure that it's an IT problem, and I'll tell you it's usually not. It's usually workflow or accountability or something else that's not really the system's fault. And then you have to be able to work through to a solution. So informatics to me is an amazing field, and you kind of get both. So if anyone is interested in how to move into the informatics field, that is definitely an offline conversation, but send me an email. I can talk to you about where you are now and your interests and some things to think about that do not involve going back to school, that could get you into, you know, the informatics field. It's an amazing place to be right now, and we have a lot to fix, so there's a lot of work.
Thank you. I presented recently to a group of nursing informaticists, and I was struck at just the, you know, the breadth of information and also the need. So I would highly encourage anyone out there listening, if you're, you know, IT inclined, and you don't certainly have to be an expert at it, it might be something for you to think about. So I just wanted to take a moment here again and bring us back full circle to where we started with TCPI. So we've touched on it and talked about it a couple of times. If there are any additional questions, or if you have an interest in learning more about TCPI, I would encourage you to visit the link at the bottom on the AANP website. It will tell you both about TCPI, but also give you some of the basics about MACRA, MIPS, and APMs. There's all these acronyms and QPP. It's happening. It may be happening in the practice where you're working right now, and you should be aware of it. So I would highly encourage everyone, go there, do a little bit of reading, and then start asking some questions where you work and practice to find out how your practice is preparing for payment reform. And that being said, and I didn't mean to do it, but I did, if you are interested in finding out more about what's happening right now with MIPS, we are sponsoring a CMS presenter for our next, it's not a lunch and learn because we'll be doing it in the evening, but we will be talking about MIPS and kind of the need to know information that you as a provider will want so you can have those conversations. Next month it'll be in the evening. It'll be a little longer than the ones that we generally do, and it's not CE accredited, but if you would like a more in-depth conversation, we will have Beth Chalik-Kaplan joining us, and I would encourage everybody to join that one as well. And on behalf of the NNCC and the AANP, Rebecca, I just want to thank you again for your time and your expertise. It's been a joy working with you, and I wanted to thank everyone for joining us today. And with that, we'll sign off. Thanks again. Bye-bye.
Thank you, guys.